Hi, everyone. My name is Alyssa, and I'm the regional coordinator for the West Virginia partner of the Mid-Atlantic AIDS Education and Training Center. And because that is so long, we usually like to call it MATEC so everyone can remember. So MATEC offers education and technical assistance to healthcare professionals regarding HIV and related topics. So we do collaborate with Project ECHO to plan this HIV prevention series. And the slides are looking good. Dr. Sori, could we go to the next one, please? So I just have a couple acknowledgments and disclosures to read. So MATEC is supported by DHHS Health Resources and Services Administration, or HRSA, as part of a cooperative agreement. You can see more about that on our website. The contents in this presentation are those of the authors and don't necessarily reflect official views of HRSA, HHS, or the government. So for more information, you can also visit hrsa.gov. Next slide, please. Any trade or brand names for products mentioned during this presentation are for training and identification purposes only. And our grant number from HRSA is on that screen as well. Next one. You can see our Mid-Atlantic region is highlighted in red there. So we're West Virginia, Pennsylvania, Delaware, and DC. And then these are some of our national resources with the links on this slide. So I think Kelly is going to upload the slides later for people to access if they would like, or Chantry. Next slide, please. So last one, our planning committee members, staff and faculty involved with planning, and the speaker, nobody has any conflicts of interest to disclose. So with that, I will pass things off to Dr. Sarwari, who is the medical director for the Positive Health Clinic. MATEC is lucky enough to share a space and several team members with the Positive Health Clinic. We are very privileged to do so, and with so much expertise and knowledge, I'm very glad to have Dr. Sarwari speak for us today. So pass things over to him. Thank you.
Thank you very much, Alyssa. Good afternoon, everyone. My name is Arif Sarwari. I describe myself as a clinician educator. I take care of patients, have been the medical director for the Positive Health Clinic, I think right from its inception, except for a short term when I served as the Department of Medicine chair. Learned a lot. The clinic has grown since its establishment in 2004. HIV is definitely one of the areas of focus for me. The topic today is HIV infection in patients on PrEP. And the main objective is really to approach this from a clinician's perspective. Do we see patients that develop HIV on PrEP? Yes. What are the basics of that I need to know? We really need to understand acute retroviral syndrome. Then we need to understand that HIV and PrEP is different for patients on oral PrEP versus injectable PrEP. And what are those differences? As a quick reminder, please open up your chat box. Keep it close to you. I have mine open because periodically I'm going to stop and ask a question. So just warning you ahead of time. The Positive Health Clinic is centered out of Morgantown. I'm going to shamelessly put a plug for it. We've been covering the northern 33 counties of West Virginia since 2004. We've been seeing patients with HIV before that, but the Ryan White funding helped us coordinate the care into a much more holistic, comprehensive care model. In addition to ID services, social work services, rapid testing services, nursing, nutrition services, we now have on-site behavioral medicine and primary care services. We serve approximately 350 to 400 patients out of our Morgantown and Benwood clinic, which is about an hour driving distance from here. And then we also provide oversight to about 150 more HIV patients seen by Shenandoah Community Health Center. where they see these patients without any ID providers on site. And over the years, this relationship has served a total of over 500 patients. We've learned a lot over the years, certainly taking care of these patients. PrEP, as you know, is a much more recent phenomenon. And more recently, we have seen a few patients that did get HIV infection despite being on PrEP. So I want to start off by discussing the acute retroviral syndrome, which also may be called primary HIV infection or acute HIV infection. And I think it is very important to start at this point. This is part of the natural history of HIV infection. And I'm going to use an example of MSM transmission, men who have sex with men, with the risk factor being higher if you have receptive anal intercourse. And we know that the risk of transmission in that setting is about 1:300, 1:500. And I want to walk us through how HIV infection occurs and how acute retroviral syndrome develops in that particular patient. Because it's once we understand that, then we can think through how does that differ from infection, acquired HIV infection when you are on PrEP. So let's take the scenario of an HIV negative receptive partner who does have anal sex with an HIV positive individual. The risk of transmission is high. As I said, it's between 1:300 to 1:500 per exposure. And the first cells that will get infected are going to be your mucosal lining antigen-presenting cells that are CD4 receptor positive. It will unfold over the next 4 to 6 weeks where enough viral replication starts to occur. These mucosal HIV cells will start draining into the pelvic lymphatics. They will drain through the abdominal lymphatics, and at about the 4 to 6 week mark, through the thoracic duct, dump billions of HIV virus particles into your systemic circulation. That is primary HIV viremia. So in about 4 to 6 weeks after the exposure, in this case, we talked about anorectal exposure, we now have billions of HIV virus particles that have now entered the systemic circulation. They will now go and seed all CD4 positive cells across the body. There is no organ system that is spared from being seeded, starting with your CNS, to your heart and your lungs, to your liver and your spleen, to all cells in the body get seeded. And this is what generates your reservoirs. I want to make sure we understand the significance of the numbers here. We are talking about billions, 10 billion HIV virions that are part of the process of seeding all the reservoirs. The exposure to the bloodstream by this very large volume of HIV viruses is not a clinically silent problem. Our immune system reacts, responds, and aggressively tries its very, very best to fight this overwhelming expansion of the HIV reservoir. That is called the acute retroviral syndrome. So how do patients present? Well, it is a viral illness. So they will present with what feels like a viral illness. They'll be achy. They may be febrile. They may have a sore throat. They may have a rash. They may have some oral ulcers. But it is a classic viral syndrome, except in this case, it's an acute retroviral syndrome. It is extremely common. When you take patients where you have had a late diagnosis of HIV and walk back to when their exposure occurred, almost in 80% of the times you will recognize the clinical syndrome, except we frequently miss it. How many times do patients present to student health or to the urgent care or to emergency rooms complaining of a headache, a sore throat, and a febrile illness? And how many times do we take a sexual history that explains that this is an acute retroviral syndrome? Not very often. It's very, very frequently missed. In fact, a few patients with acute retroviral syndrome will even be hospitalized. We have seen patients with aseptic meningitis, hospitalizations 3 years ago, when we later find out they are HIV positive. So the key point I'm trying to make here is acute retroviral syndrome is very common. It's frequently missed. It is a clinical syndrome based on the response to the primary HIV viremia, which is a dumping of billions of HIV virion particles throughout your bloodstream, an extremely high volume of virus. The viral loads, when measured in acute retroviral syndrome, are usually in the millions. Now, what happens is that once the immune system kicks in and starts fighting the HIV virus, that viral load of 1 million does come down to the tens of thousands or hundreds of thousands and then stabilizes at that level. We call that the viral set point. Every individual patient with HIV has a different viral set point. The viral set point is based on the pathogenesis of the HIV virus in combination with the immune response. Some patients with a very robust immune response will have a very low viral set point, and they will take a lot longer to progress from acute retroviral syndrome to full-blown AIDS. Others will have a much higher viral set point, and they will progress faster. We talk about HIV-positive patients on average having a viral set point about 100,000 and having a CD4 decline of about 100 cells per year. And that gives you an estimate of the natural lifespan of somebody with HIV, which is about 10 years. Because you start off with 1,000 CD4, you decrease by about 100 per year. We also know that HIV transmissibility completely correlates with the viral load. So if I'm telling you that in the acute retroviral syndrome, my viral load instead of 100,000 is in the millions, this is an extremely transmissible state. In fact, just to put some numbers on it, I gave you an example of anorectal exposure with an estimate of 1 to 300 to 1 to 500 transmission. That risk goes up by 100-fold, 1 to 3 to 1 to 5, when the partner is HIV positive and in the acute retroviral phase. Those viral loads are extremely high. So acute retroviral syndrome needs to be identified more often, frequently missed, extremely highly transmissible state. Should we be starting HIV treatment during acute retroviral syndrome? Absolutely. The rapid initiation of HIV therapeutics during acute retroviral syndrome has not only a public health benefit, but also a patient benefit. What is the public health benefit? Well, we've just talked about risk increase and risk escalation by 100-fold. So absolutely, anything that will bring the viral load down will decrease the risk and future transmission or further transmission from this patient. What about patient benefits? Well, to me, HIV viral replication is the primacy of what we're dealing with clinically, right? Anything that you can do to turn off HIV viral replication has a patient benefit. In the acute retroviral syndrome, the best patient benefit is you decrease the spectrum or the reservoir that gets infected. You've got fewer viruses that are going around and infecting the CD4 positive cells of the body. Okay. Here is a depiction of the different testing that we use to identify patients at different stages of HIV infection. We know there is an eclipse period where about for 10 days after HIV exposure, we are not able to make a diagnosis. The first marker of detection of HIV is our nucleic acid testing or the viral load. That starts going up and goes to a very, very high level in the millions, decreases as the immune system kicks in, and then plateaus for a time based on the viral set point. And this is clinically symptomatic. The next biomarker that goes up is our P24 antigen, which is a part of the capsid protein. That does go up and then falls. And then you have your IgM and IgG responses. Okay. Now, if your HIV viral load goes to millions and billions, as it does in acute retroviral syndrome, if you have large quantities of P24 antigen, you will trigger a robust immunologic response with significantly high levels of IgM and IgG. Except for the timing, they will be positive. Well, what if there was a scenario in which the amount of RNA virus was lower? Would you have the same amount of antibody production? Would it be delayed? Would it be lower peaks? Would you have more trouble detecting it? And those are things I just want to keep in mind as we talk about HIV infection in patients on PrEP. All right, so let's start with HIV infection in patients on oral PrEP. We have two regimens. We have TDF with emtricitabine, also called Truvada, and then we have TAF with emtricitabine, also called Descovy. And my first question to you is, if a patient on oral PrEP does get HIV infected, do you think this is a problem with adherence, or do you think this is a problem with resistance? So we've had 3 to 5 patients who did get HIV infection on oral PrEP. And of those 3 to 5 patients, do you think the basic problem was adherence or resistance? Please put your response in the chat. I think pretty good consensus there, right? This is an adherence problem. This is not a problem with the medication not working. We've got tons of studies. You take PrEP, it works. When your blood levels are measured in people who take PrEP, it works. There's no problem with it. The problem comes in when you don't take it as prescribed. We, in fact, have an estimate for if you take it 7 days of the week versus 5 days of the week versus 3 days of the week in terms of the efficacy of the PrEP. But HIV infection in patients on oral PrEP is an adherence problem. It is remembering to take your pill every day. That's it. So if it is an adherence problem, and that was true for the few patients that we saw with acute HIV infection or with HIV infection in PrEP, if it is an adherence problem, then should you have any difficulty recognizing the clinical syndrome? Should you have any difficulty with your testing? The short answer is no. It has been noted that for patients that do take their PrEP intermittently, there may be a lower peak viral load and there may be fewer symptoms. There may be prolonged seroconversion. In other words, instead of converting from a negative antibody to a positive antibody within 2 to 3 weeks, it may be a little prolonged out. But this is not where we have difficulty with diagnosis. Acute HIV infection or HIV infection in patients on oral PrEP is an adherence problem. It does not behave any differently than HIV infection in patients who were not on PrEP, except that you may have a lower viral load. You may have had fewer symptoms. So this is not the challenge. So next question for you. If their viral load is lower, if the seroconversion may be delayed, should patients who are being monitored on oral PrEP, I mean, we take our patients' word for it, right? They're taking their medication. They say they're taking their medication. Instead of simply monitoring an antigen antibody fourth generation test every 3 months, should I also add an HIV RNA every 3 months for patients in oral PrEP? And that's an open question for everyone. So yes, no, do you add an HIV RNA test for patients on oral PrEP? And that is the current CDC recommendation, that we do monitor both antigen antibody, but also the viral load. Okay. If you were to have conversion, what levels of HIV RNA do you think you would see? Thousands, tens of thousands, hundreds of thousands? Next question for you. And again, we're generalizing, but I just want to try and get a sense of where you think this viral load is going to be. So the question is, in a patient on oral PrEP who does get HIV infection, which we've established is mainly because of adherence, what do we think their viral load will be? Will it be in the thousands, the tens of thousands, or hundreds of thousands? And I think both those answers are correct. So low to thousands, to me, anything less than 10,000 is a lower viral load. So that is correct. So this is seldom seen where you have the 1.5 million, unless somebody has really been off oral PrEP for 6 months. And this is much more likely to be in the thousands. Okay, agreed. All right, let's go to injectable PrEP. Undoubtedly, injectable PrEP is much more efficacious. No doubt about that. Now, you're basically giving an injection every 2 months or every 6 months, and adherence is not the question here at all, right? So this is not a question of getting HIV infected because you forgot to take your pill. This is now becoming from an adherence problem to a resistance problem if you have breakthrough. So let's look at a few numbers here. Hapten 083, 084 were the 2 landmark randomized controlled trials with cabotegravir injection, which is the currently commonly used injectable PrEP. The 2 trials combined together had 41 out of 3,500, or about 1.2% HIV infections. Of the 41, diagnosis was delayed 17, and 10 of these 17 had resistance issues. So oral PrEP, adherence problem, injectable PrEP, this is a resistance problem. Okay. Now, we can ask the question, when did the infection occur? Was this an unidentified infection right as we were starting injectable PrEP? Or was this infection while on injectable PrEP? And it's probably a bit of both. The ones that are resistant are definitely going to be the ones that are breaking through There's one interesting statistic that comes to mind in the pathogenesis of HIV infection. It is known that for a person with a viral load of 30,000, each and every possible mutation is generated in a day. So the mutation that confers cabotegravir resistance can be generated within a day as well. So I think it's just a reminder to me that, yes, with injectable PrEP, you can have breakthrough. Is there a difference between cabotegravir versus lenacapavir? So Purpose 1 and 2 were, again, very interesting landmark controlled trials, which showed us the effectiveness of every 6-month lenacapavir compared to oral. And in the lenacapavir arms in Purpose 1 and 2, there were 2 infections out of 4,300 patients, giving you a breakthrough rate of 0.05%, as compared to 64 in 4,200 or 1.5% on oral PrEP. That was the control arm. Okay, so it is a rare occurrence. I know we are talking about HIV breakthrough on injectable PrEP. Yes, we are worried that this happens, but it is not a very common occurrence. Okay. The problem with this is that the diagnostic tests are atypical. So how do I wrap my head around this diagnostic tests are atypical? Going back to the graph I showed you with the testing, that peak is not tens of millions and billions. That peak is lower. When that peak is lower, everything else is lower or not detectable. And that's where the problem comes in. When we have HIV infection in patients on injectable PrEP, it becomes harder to diagnose. It is a clinically asymptomatic stage. Okay. This is, excuse me, a comparison between what happens in acute retroviral syndrome or classic acute HIV infection and acute HIV infection in the context of long-acting injectable PrEP. And you might hear the term Levi syndrome, Levi as in the genes, long-acting early viral inhibition syndrome. Very different entities. In the classic acute HIV infection, we've talked about how we have this huge viremia, tens of millions of particles, a set point, and then you stabilize, which is often symptomatic, and a robust antibody response based on this huge exposure. What happens in the Levi syndrome, long-acting early viral inhibition syndrome, when you get HIV infected, the viral peak is very low. We are talking about hundreds to even low thousands. We're not talking tens of thousands. We're not talking 1 million. And because this viral peak is low, the stimulation of the immune system to start producing antibodies is also affected. And your antibody tests may be positive and then go back to negative depending on the threshold of detection. Let's say the threshold of detection is right here, then you will have a positive test that then becomes negative. Your RNA levels are also low. You never get that huge, robust viremic phase. Levi syndrome, long-acting early viral inhibition, is characterized by 3 themes. Number 1, low HIV viral loads, sometimes undetectable, depending on the assays you're using. A delayed antibody response, and the detection assay that has the potential to revert. Meaning what? Reversion means positive, then negative, then positive, then negative. So it may go back and forth because remember, all our tests have thresholds. You know, this is not one of those that is going to remain persistently positive. Okay, so you can begin to understand, ooh, this may become a bit challenging to diagnose. All right, let's take what we've learned and apply this to a case. So This case, courtesy of Kelly Berner, who runs our HIV PrEP clinic, is a 35-year-old male on long-acting cabotegravir for pre-exposure prophylaxis. The patient has a BMI of 35, well-controlled diabetic, and an underlying idiopathic urticarial syndrome. Currently monogamous with a male partner for the past 1 year, with both partners on PrEP. Excellent adherence with their clinic visits to get the injectable PrEP. In 2024, you can see the dates, March 19th, April 16th, every 2 months, getting their medication on time. Prior to their starting injectable PrEP, HIV was negative, hepatitis C negative, STI screen was all negative, and the patient is hepatitis B immune. On February the 4th, the patient presents to the clinic extremely upset because the evening prior, they had done their every 2-month testing, and they got this result. HIV antigen antibody positive, differentiation assay negative. What would you do? For the testing? Any history questions? Okay, let me ask the question. Oh, HIV viral load. Okay. Are we worried about Levi syndrome? Probably. Now, you know that the 4th generation testing comes back faster. Our viral load is pending. You just told me order viral load with these patients, so it's pending. It's going to take another 2 days. Our lab here runs it every, once or twice a week. So I don't have the results with the patient in clinic with me at that time. Viral load is pending. I agree. That's the main piece of information we need. What's the viral load here? It's the date the patient needs their next cabotegravir dose. Should I go ahead and administer it? Yes, no. Okay, perfect. Agreed. Would anybody repeat this test? This test comes back very quickly. Should I just go ahead and do the test again? Oh yeah, agreed. Okay, here's your result. Does that make you feel better or worse? So repeating the same test a day later didn't give me any more information, right? I need the viral load result. I really need to know what's going on. What's the viral load result here? So yes, you do need some history information. Number one, is this still a monogamous relationship? Are both partners mutually monogamous? I mean, that's critical. Has there been any risk? Number two, was there any recent clinical syndrome? Well, ironically, this patient did have a recent illness in the last couple of weeks. Nothing major, just achy, felt ill, recovered spontaneously, recovered well. Didn't need to go to a healthcare system. Okay. We're waiting for the HIV viral load here, right? And that really is going to be the key to driving what you do. The patient's HIV viral load from the February 3rd sample came back negative, target not detected. And on the 7th, they went ahead and got their cabotegravir. They came back 2 months later on April the 7th. This time their testing was negative, the differentiation assay is negative, and their HIV RNA PCR is negative. Is this Levi syndrome? Again, yes, no.
There's a bunch of people saying yes.
What's the alternative diagnosis? This could be either Levi syndrome or fantastic. Okay, so I hear COVID and false positive test. Can COVID give you a false positive test? You may not be very sure about that, but this is fine. Maybe there are on other antivirals. This particular patient, this was a false positive, fourth generation assay. The viral loads persistently remained undetectable. There is some literature that suggests that patients with a recent COVID illness may have a false positive fourth generation antigen antibody test. And I'm not sure that's exactly what happened, but I present this case to highlight the fact that we are so much more likely to see a slightly atypical presentation of a more common problem, false positive test, than we are to see a really rare problem, which is the Levi syndrome. You are much more likely to see this problem than you are to see a true Levi syndrome. Okay, and that's the purpose of presenting this patient to you. Okay, all right, what are the key take-home points? HIV infection in patients on PrEP, especially the injectable PrEP, is a very rare problem. With oral PrEP, it's more common, but with oral PrEP, it's an adherence issue. It's like if you don't take your medicine, it won't work. And yes, you can get HIV infection. Your viral loads may not be as high, but it's less of a diagnostic challenge. It's the diagnostic challenge is on the injectable side. You do need to be aware of Levi or long-acting early viral inhibition. Early viral inhibition. Inhibition to the point where your viral load is so low that you don't have the same stimulation of the immune system to form robust antibody responses. Levi syndrome is an asymptomatic syndrome. It needs to be contrasted to the very different acute retroviral syndrome, which is a robust response to a very high viral load in the natural HIV infection. And because you have low viral loads, because antibody production is delayed and decreased, you have very significant testing challenges in patients with Levi syndrome. However, given how rare it is, you are much more likely to see a false positive test in a patient that you're following than a true Levi syndrome. All right. With that, I'm happy to take questions and comments from others.